disclosures. I currently receive research support from BioMarin. I've been a consultant on the Data and Safety Monitoring Board for Ionis, formerly ISIS Pharmaceuticals, which changed its name for obvious reasons. And I will be talking, obviously, about experimental therapies in this research update session. This is a brain. Specifically, this is the MRI of a MPS brain. And you are looking at this brain as if you were looking down from the top of the head. So this would be the front, or the faces. Wait, can you see that? You probably can't. Let me see. I got to get a laser pointer. I got to get a laser pointer icon. No, that's pen. Arrow. Oops. Does this show up? No, it doesn't show up that way. Oh, it does? You can see the arrow? Okay, I'd rather do the arrow because I know it'll show on both screens at the same time. So I'm not good enough to use a laser pointer on two screens at the same time. Okay, so this would be your face. This would be the back of your head. This is the ventricles where the cerebrospinal fluid is. It's dark on this particular MRI scan. And so people will talk about giving enzyme therapy into the brain, like the way that, say, BioMarin is doing for their Sanfilippo B study, Vinaglu IGF-2. It goes into the ventricle here. This is called the lateral ventricle. There's also cerebral spinal fluid on the outside part of the brain. So when you give it, say, as Dr. Whitley was talking about, you give a gene therapy into the cistern at the base of the skull, that's going to primarily travel over these convexities here, but also some would probably make it into the ventricles. And so that's where the cerebrospinal fluid is. You also have gray matter and white matter in the brain. So the gray matter is this kind of whitish area on the convexities here of the brain. And the gray matter is where your brain cells are, your neurons. And then the white matter is actually dark in here, the part underneath that. And the white matter is where the connections for your neurons are. Now here in this MPS brain, what you see are these cystic areas, these kind of holes. And what those holes represent is glycosaminoglycan storage that's kind of sitting around blood vessels that kind of penetrate in through the brain. And those probably don't cause too much trouble, they just kind of sit there. And then there are these white areas, these patchy whitish areas inside the white matter. So the white matter is otherwise dark in this scan, but these white matter areas are patchy. And these may cause a problem that could lead to, or they seem to be correlated with some measured domains of intelligence as well as attention loss for certain white matter areas. So this is the part where we want to study in MPS. So what is in the white matter? So we talked about connections between the brain cells. So I don't know how much of your neurology or neuroanatomy you might remember, but you have, in your nerve cells have these projections called axons, and that's how nerves or brain cells talk to each other. And in your axons are wrapped with something called myelin, and the myelin in the brain comes from a cell called the oligodendrocyte. And the oligodendrocyte will wrap its cell membrane around the axon, leaving gaps which are called nodes of Ranvier, where you have electrical impulses traveling down the axon with sodium and potassium exchange throughout that. This allows conduction to proceed more rapidly than it would if you didn't have a myelin sheath. And so this sheath, this myelin sheath, I think about it as the rubber around a wire, an electrical wire, wraps many times around that axon to help conduct the signal. So in MPS, we see white matter changes on the MRI, and we don't know what it means. And these are specifically seen in MPS type 1 and MPS type 2 primarily. When we look at electron micrographs, we see a disrupted myelin sheath. This could be potentially due to loss of those cells that make myelin. There could be some problem with the way the myelin is put together. And there could be some contributions of that abnormal myelin to, say, the loss of volume when we measure the volumes of the white matter and the gray matter in the brain. And there could be some interaction with the hydrocephalus or enlargement of the ventricles that we see in some forms of MPS, which might put pressure on the white matter regions of the brain, causing abnormal white patchy signal that we see and maybe even causing problems with myelin. Or there could be problems with the nerve cells themselves and the connections, the axon in the middle of the myelin that could be causing this problem. So to try to study this, we have been using the canine model of MPS I in collaboration with Matthew Ellenwood at Iowa State University, who has had the model and collaborated with us for over a decade. And so now what you're looking at is a dog brain, and this is the nose of the dog would be over here. This is the back of the head of the dog, and you're looking at it at the sideways view of an MRI scan. So this is just an MRI scan of the dog brain. And this is a white matter structure called the corpus callosum. And the corpus callosum is responsible for communicating between the two halves of your brain. So it's a bunch of white matter tracks, a bunch of axons, nerve fibers that kind of run left to right along this. So if you're looking here at the corpus callosum, all those little axons would look like little donuts covered with myelin. So what we first decided to do was study whether we can see these abnormal white matter lesions in the MPS I dog that would make it a good model for us to study. So the corpus callosum here in a carrier animal is shown. You can see it's nice and thick. And then in our MPS I dog, we see a thinning of the corpus callosum. With intrathecal treatment, and this was doses starting at 4 months of age, so not from birth, but a little bit later, we see that the thickness is maintained. And this was quantitatively measured by Igor Nestrasil using the scans, doing a whole corpus callosum volume assessment, where the MPS I dog showed less corpus callosum volume, and the intrathecal treated dogs showed preservation of volume. What we can also do in the dogs is study the composition of the white matter by taking the corpus callosum out after the animal is deceased and evaluating the white matter myelin inside for its composition. This was done using mass spectroscopy, looking at the amounts of what are called polar lipids and the different, and ceramides and hexosyl ceramides, which are just different types of lipids. And the point is we did find some abnormalities in lipid composition in the MPS I dogs in the myelin, and so there is some abnormality there. We also studied the expression of myelin-related genes, and we did this in a variety of animals, of ages of animals. So first we started looking at the older animals that are about 18 to 24 months of age. So this is the expression of genes related to myelin. So basically when your body wants to make protein, when your cell wants to make a myelin protein, it's going to express that gene, and that's going to then make the protein. So we're measuring the levels of what we call messenger RNA that tell us whether that protein is going to be made. So what we found was a decreased, a kind of subtle but consistent decrease in the expression of these genes related to myelin in these older dogs. And those are the black bars here. This is the normal mean here, the ones across all of these graphs. And these are dogs that are 12 to 18 months old. We saw a similar phenomenon. And then we looked at younger dogs, age 4 to 6 months, and we still saw a reduction in the expression of these myelin-related genes. Interestingly, we had some dogs that had been treated with a variety of regimens. Here, the gray bars are the animals that have been treated with intrathecal enzyme replacement therapy, but only starting at 4 months of age. These animals have been treated with intrathecal or intravenous therapy starting from birth, and these are the gray and the white bars showing that they looked like some preservation of the expression of those genes. And then these are white bars of dogs that were treated from birth with a relatively high dose of intravenous enzyme replacement therapy from birth, and they had preservation of their expression of myelin genes too. Yeah. So an untreated MPS I dog typically lives about 3 to 4 years, and it's mostly the physical disease that they get. So looking at electron micrographs allows us to really look at those donuts that I mentioned. So you have your axon in the middle here and the myelin sheath around. So we did this in the corpus callosum in collaboration with Miguel Guzman, who took over from Carol Vogler at St. Louis University. So this is a control animal at 24 months, and you can see pretty nicely formed donuts of myelin around in the corpus callosum. In the MPS dogs, we see some, what looks like some disruption of the myelin sheath, as well as some thinner myelin in the corpus callosum. Interestingly, in animals as young as 6 weeks of age, what we saw was what looked like it might be a delay in myelination, where there might be a smaller number of axons that have a myelin sheath around them. And so we studied the expression of myelin-related genes in dogs as young as 6 weeks of age, and even then we saw a reduction in the expression of these genes compared to the control mean of the similarly aged carrier dogs. And so to try to tease this out, we've turned to our friends at Duke University who have a 7 Tesla magnet for scanning dog brains ex vivo. And this is a scan that occurs over about 50 to 60 hours. They basically leave the brain in the scanner for the weekend. And we get a super high resolution MRI scan of the canine brain. So this is a dog where you're basically looking at the dog. So this is as if so this would be the top of the head. You have the left and right sides. And this is your corpus callosum, that tract that separates left and right hemispheres. For this study, we looked at what's called the internal capsule, which is this, you can't see it because it's covered with these regions of interest, but they put 100 regions of interest in the front part or anterior and the back part or posterior limbs of the internal capsules, just another white matter structure. And they also looked at the centrum semiovale, or CS, which I've mislabeled in the other slide, so I'll mention that. It's this area here, this white matter area. And so we did that in MPS 1 and control dogs, age, the ones we had were 7, not 6 weeks, but similar age. And what we found was very, very interesting. So at 7 weeks, by imaging at least, what we found is that there was a pretty similar result between the MPS and the normal dogs. Now what we're looking at here is something called fractional anisotropy, or FA. And the important thing to know about FA is basically it goes down when you lose white matter integrity, and that's mainly when you lose myelin. So if you have a loss of myelin or too little myelin, usually your FA is going to be low. And this is measured by something called DTI, or diffusion tensor imaging. So in the AIC, which is the anterior internal capsule, and the PIC, or the posterior internal capsule, what we saw was, if anything, the MPS dogs had maybe more myelin or somehow increased FA compared to the normal dogs. And the same in the centrum semiovale, or anterior and posterior centrum semiovale, where we saw very similar FA in the 7-week-old dogs. However, when we measured dogs that were just 18 weeks old, what we saw was a decrease in the FA. And this is, on this side here is the normal animals. These are the MPS animals. This is work in progress, so excuse the images for not being perfect. But the MPS dogs have a reduction in FA in the internal capsule, as well as in the centrum semiovale by 18 weeks old. So something is happening between 7 and 18 weeks to either cause a loss of myelin integrity or otherwise alter the FA on our imaging studies. So we were able to partner with Ivan Tkach and Igor Nestrasil here at the University of Minnesota. They have the Center for Magnetic Resonance Research, which has this incredible collection of MR scanners. And for this study, we used mice, and we looked at the corpus callosum of the mice with a 9 Tesla, very high resolution magnet, just looking at that slice of corpus callosum and putting what we call a voxel on the corpus callosum to measure the spectrograph. So this is kind of like, they do this for newborn screening. You get MR spectroscopy to look at all the different chemicals in the body at birth to try to determine whether there's a metabolic problem. You can then do this in the brain too, and you get a spectrum in the brain. But with these high resolution scans, we could look at something, we could look at some of the fatty acids like phosphatidylcholine and phosphoethanolamine, which are something that you usually can't do in a regular study. So we evaluated these mice, MPS I and control mice. And interestingly, we looked at their, so the mice basically had very little difference, even at 50 months of age, about a year of age, 50 weeks of age, sorry, about a year of age, which is pretty old for a mouse. And in terms of their myelin-related gene expression, they had about the same amount of expression of myelin-related genes as the control. So the MPS I mice don't seem to have as much of the deficit in myelination, at least at that age. What's really interesting, though, is when we studied MPS I mice at 16 weeks of age, we did see a decrease in the expression of myelin-related genes at that age, which suggests that something unusual might be going on early in the course of the disease versus later, or perhaps that by 50 weeks, myelin is pretty much formed and none of these genes are really expressed at a high level in any case. And we didn't see composition abnormalities in the myelin of the mice at 50 weeks versus the controls. However, what we were able to do in our scan was to correlate the value of phosphatidylethanolamin by tissue with phosphoethanolamine studied on the MR spectrograph, so that we see a positive, not super tight, but positive correlation between those two values. So it may be possible for us to measure myelin integrity, or at least some of the lipids involved in myelin, using this modality, which is an in vivo modality of imaging brain. So we are continuing to study high-resolution neuropathology and neuroimaging and its correlation with neuropathology in MPS I dogs, and hoping that this will shed some light on myelination and what role it might have in the pathophysiology of MPS disease. Now, moving on to something that Joe mentioned and alluded to and talked about, we have been working on intrathecal enzyme replacement therapy in clinical trials of mucopolysaccharidosis type 1, following on work done in dogs. And for MPS I, for this study, we chose Hurler-Scheie and Scheie forms of MPS I. And Hurler syndrome, as you know, there's hematopoietic stem cell transplantation, which can arrest or attenuate the cognitive decline, but enzyme replacement therapy doesn't typically do this for Hurler-Scheie and Scheie patients. And while many of them have a completely normal intellect, there are subtle differences in cognition and some intellectual domains that can occur over time, and declines which we thought we might be able to arrest. So the point of this study was to determine whether we might stabilize cognitive regression using intrathecal enzyme replacement therapy in MPS I compared to a control group which was untreated for a year or two and would be expected to demonstrate a decline. And prior to the conclusion of this study, there was a case report published by Igor Nestrasil last year of a patient who received intrathecal enzyme replacement therapy and did show some improvements in cognitive domains. So this is a table from that paper, which I believe was from the American Journal of Medical Genetics, showing some improvements. This is a verbal IQ, some different IQ domains, tested variables of attention. This is commissions. And 2 years and 3 years out after intrathecal enzyme replacement therapy, there were some improvements. This is a percent difference, so about a 7% improvement in those measures at that time. Some other changes here. There were also imaging studies that showed some differences as well. So in this study of attenuated MPS I patients, there were 8 subjects. They were, the inclusion criteria was that they be 6 years of older. All were over 12, and they had to have evidence of cognitive decline in at least one domain. They received recombinant human alpha L-glucuronidase as loranidase, 1.74 milligrams, mixed, as Joe mentioned, with Elliott's B artificial spinal fluid solution. So the volume was 9 mL, which is probably about the maximum we can deliver with a single bolus dose of a lumbar puncture. And they received 1 dose per month for the first 4 injections, and then every 3 months for a total of 2 years, with control treatments receiving no treatment for the first year, and then everyone received treatments after 12 months at 3-month intervals for a total of 4 doses in the second year. This is a example of one of the study of one of the domains of IQ. This is the full-scale IQ. Basically, all of the cognitive domains looked similar to this. The front parts of each of these graphs, so this is each of the individual subjects graphed separately. This line represents the end of that first year when then everyone subsequently went on treatment. And then this graph is the average of the treated patients and the controlled patients. So the blue represent the subjects who were on treatment during the initial phase. The red represent patients who are not on treatment during the initial phase. And basically the IQ and all this was the same across all the domains, was pretty stable throughout this 2-year period. And so we can't really say, because we didn't demonstrate any loss of IQ in the control group, whether we had an effect of intrathecal enzyme therapy. Adverse events were relatively mild. We had serious adverse events related to treatment, which was a headache, which prolonged hospitalization by 1 day. There were other serious adverse events that were deemed not related to treatment. So in summary, this is a safe but challenging procedure. There were no significant differences in efficacy outcomes, but no decline in the control group. And it just suggests that we may need more time to assess these, and so we currently have a 5-year extension study to evaluate intrathecal therapy for these subjects. So there's a clinical trial of adalimumab, or Humira, for MPS I and II. This is being conducted by Linda Polgreen at our institution. This is data from a pilot that she performed looking at 2 patients, one with MPS I and one with MPS II. And the patients were in a double-blind study, which means they were given an injection of either saline or placebo or the study drug, and they didn't know which was which, and the doctors didn't know which was which. So one subject received the treatment for 16 weeks, followed by placebo injections for 16 weeks, and the other was the reverse. So she studied pain and general physical function in these patients. So this was subject 1, who was a Hurler MPS I subject, status post-transplant, and who was 15 years old, and subject 2 was a 6-year-old MPS II attenuated on enzyme replacement therapy. So during the treated phase, which you can see here, the subject had a relatively stable bodily pain score, an improved physical function score, and then during the placebo phase had a reduction in, had a worsened bodily pain score. And in subject 2, you see in the placebo phase, you see a worsening bodily pain score and improved bodily pain score in the treatment phase. She also found improvements in range of motion with the treatment in the treatment phase. And safety measures, the adverse events were relatively similar in placebo and treatment, all of them mild and or resolved without intervention. So this study, there's currently a follow-up to this pilot study that will hopefully determine whether these results can be replicated. Okay. So we are studying the role of antibodies in loranidase treatment, and we've been doing this for some time. And the antibodies form, as you know, in patients who are on intravenous enzyme replacement therapy, and they're thought to have no effect on safety. However, there is a concern that these antibodies might interfere with the effectiveness of therapy. So we performed an MPS I mouse study giving them intravenous loranidase at a relatively high dose for 16 weeks, and they were given it weekly through infusion. So the mice had very low antibody titers. So 20 is considered what we would consider low in our in all of our MPS I patient assessments that were done by Emil Kakkis and published in I think the 90s or early 2000s. So the mice had levels that were well below that, what we would consider clinically relevant antibody titer. So the dark mice were basically, we didn't detect any antibody, and the white ones here, we detected some antibody, and there's 5 in each group. So in the dogs, what we had found was that with very high titers, which they had, we saw a reduction in the uptake of the enzyme into fibroblasts. And so we postulated that that was causing problems with the effectiveness of the drug. But in the mice, even with these very low antibody titers, we saw a reduction in the uptake of enzyme into the liver. And what's interesting is it's not just a reduction in uptake, but it's preservation into these sinusoidal cells, a lot of which are macrophages. And whereas the liver parenchymal cells had enzyme only detectable by antibody only in the antibody-negative mice. So we performed an evaluation of mouse macrophages and human fibroblasts and looked at the uptake per cell or actually per million cells in each cell type. And what we found was really interesting. So if you focus here on this white bar, this is the macrophages, and this is the enzyme that we've applied. This is no antibodies present. If you give immune serum, so this is the mice with antibodies that inhibit, so this is that inhibit uptake, what we find is that there's an improvement, an increase in the amount of enzyme that gets into macrophages, whereas much less gets into fibroblasts. But if you take the antibodies that are not even enough to inhibit the uptake into fibroblasts, you still see the uptake into fibroblasts like you did before, more or less, but the uptake into macrophages now exceeds what you see into fibroblasts. And so what we think might be happening is that the antibodies to the enzyme, they don't just decrease distribution into the fibroblasts, they actually alter distribution, so you get more into macrophages. And what this may mean clinically is that your assays that evaluate whether fibroblast uptake is inadequate might not be good enough to determine if your antibodies are actually having an effect. So, we have a few other projects. We have some mice cannulated that we are studying intraventricular NAGLU-IGF-2 for Sanfilippo B. This is a mouse with we call them unicorn mice. They have these little brass caps on their heads for dosing intraventricular enzyme. Looking at stem cell therapy for Sanfilippo, biomarker development, and clinical trials I had already mentioned before. That's all I have. I wanted to thank all our collaborators and take some questions.